The next part of the examination of the knee, we will be looking at the extension and flexion of the knee. Again, this is full knee extension. If the knee had hyperextended, we term that recurvatum. Also, flexion of the knee, we're looking at whenever we flex the knee, we wanting to compare side to side. Flex the other knee also, please. And you can see that sometimes we check the distance between the heel and the buttock, and that tells us if there is symmetric flexion of the knees between both sides. As you can see, Dave's right knee does not flex as much as the left one, and he has had, since he has had multiple procedures done on this right knee. Let's go ahead and extend again. Some patients come in with a flexion contracture of their knee. That's where their knee is just flexed to about this position, and they will not allow you to passively extend their knee for them. Their knee is just stuck in that position. Usually the problem is that there is a bucket-handled meniscal tear, or there's been an anterior cruciate ligament tear, where something is stuck inside the joint, keeping the patient from fully extending the knee. Okay, you can relax it now. An extension lag is different from a flexion contracture. An extension lag is where the patient attempts to extend the knee, however they are unable to do so. However, when the examiner takes the knee and extends it for them, they're able to do so. The reason for that is that usually there has been an injury to the extensor mechanism, either a quadriceps tendon rupture or a patellar tendon rupture, and basically the patient can only extend the knee to about this much, but then they are unable to actively move it. However, again, the examiner is able to extend the knee. The next portion of the knee examination is palpation of the knee. Again, we initially palpate the patella. We want to palpate the medial facet as well as the lateral patellar facet. Also palpating around the quadriceps region as well as at the superior pole of the patella, as well as palpation at the inferior pole of the patella. In this region, if there is any inflammation, it's usually due to, we usually see this in jumper's knees. The other fancy term for jumper's knee with pain in this region would be Sinding-Larsen-Johansson syndrome. Again, as you can see, it's much easier to just say jumper's knee. Also, tendinitis can occur between the patellar tendon, at the patellar tendon insertion onto the tibial tubercle, and also young people ages 11 to about 15. They usually come in with swelling in this region due to Osgood-Schlatters disease. The next thing in palpation, palpating on the lateral aspect of the knee, again the fibular head, the lateral collateral ligament. On medially, again we're palpating the medial collateral ligament as well as the pes anserine region. The other thing that we palpate is the anterior joint line laterally as well as medially, and we want to palpate all the way posteriorly along the joint line, both on the lateral side as well as on the medial side. Usually pain that is anterior to the cruciate ligaments up in this area usually relates more to chondral injury or lining cartilage, articular cartilage injury inside the knee. Pain that is usually occurring on palpation posterior to the collateral ligaments at the joint line is usually due to the menisci, meniscal tear usually. Again, we also want to feel the biceps femoris tendon on the lateral side, and again on the medial side we're able to palpate the medial collateral ligament as well as the semitendinosus and then the semimembranosus muscle across this region here. Okay. The next portion of the exam is muscle testing. We want to examine the resistance testing to the quadriceps muscle by holding the leg in full extension, asking the patient to keep the knee fully extended, keeping me from flexing his knee, and that is how to examine the muscle strength for the quadriceps. And another way of looking at to see if there's any atrophy between one side and the other You usually take a measuring tape and measure the quadriceps circumference at this level and compare side to side. Go ahead and turn around. In regards to the strength testing also for the hamstrings, again, you want to ask the patient to maintain flexion of their knee, and you attempt to extend their knee, thereby seeing what their strength is. The next portion of the examination is the sensation examination. One of the main nerves around the knee for sensation is the infrapatellar branch of the saphenous nerve. That's a nerve that comes down across this area from medial to lateral and crosses in front of the knee. With any midline incision in the front of the knee, that usually transects that nerve, and it's not a nerve that is easily visualized, and therefore most patients with a midline incision will have numbness across the lateral aspect of the knee, which is very common after anterior cruciate ligament reconstruction, as well as after total knee replacement. The next portion of the physical exam on the knee will be looking at special tests of the knee. Basically, we're looking for knee effusion. We're also looking for any ligament injuries like the medial collateral, lateral collateral ligament, anterior cruciate ligament tear, and posterior cruciate ligament tear. The very first test is looking for a knee effusion. Most people think that the patella is the superior aspect of the knee. Actually, the knee continues on for about an inch or so superiorly into the suprapatellar pouch. If there's any fluid in the knee, usually it will build up in this region. The best way to check for a knee effusion is that you want to milk some of this fluid that is in the suprapatellar pouch and try to see if you can palpate it inferior to the patella.